Hi, sorry, we've actually, Rachel forgot to remind me to record. So it wasn't my fault. We've missed about 10 or 15 minutes at the beginning, so I'm going to re redo it basically as much as I can remember anyway. So the question came up was about pure swings, impure swings, and so on. And this is basically the first part of this. So a swing, an arthrokinematic swing, is a translation across the articular surface. So if we're looking at the glenohumeral joint, so a swing would be this movement, okay, that type of thing, up and down, backwards and forwards, and so on. It's worth saying now, though, that that swing doesn't occur normally with active movement. So I know you've been told this. If you abduct your arm, the head of the humerus glides down, but that's not what happens. Because of the dynamic stabilization from the rotator cuff, biceps, and all the other stabilizing muscles. They keep the humeral head in place, centered. So instead of it sliding up and down, it actually skids on that central surface. So it stays in that same spot, but it skids. But what you can see, there's still translation of that head going on. Passively, that's exactly what does happen. So if you want to test abduction, for example, you would glide the humerus down on the acetabulum. But actively, that doesn't happen unless it's dysfunctional, unstable. When it does happen, of course, when it does start to actually translate up and down or backwards and forwards, it beats up the labrum because the labrum is there for mid-range stabilization, and it gets beaten up by the humeral head if it's unstable. So ideally, it doesn't move, it skids on that surface, but your passive understanding of the joint is fine. Um, you can think about it in those terms. If you're restricted in abduction, then it means essentially, if it's not a biomechanical dysfunctional piece of labrum blocking it, is that the capsule won't allow that movement to occur. So you've got the capsule holding it back there. It's also going to limit the amount of movement it can do here. So you would test inferior gliding if abduction is lost. And if you find that you've got a hard capsular end fill or a biomechanical block, the problem lies within the joint and the joint capsule and the ligaments. If that's okay and you still can't get abduction, then the loss of abduction is due to an extra articular hypomobility, generally muscle. So normal function is it doesn't actually translate, it skids in place. Passive translation, passive movements, it will translate. So when we're looking at a pure swing versus an impure swing, the impure swing has spin involved. Now, spin is where there is no translation occurring, and it's actually a rotation around the axis of movement. So it's doing this rather than the axis of movement moving with the bone. So it spins this way, and there's no translation, no swing. So is if there's a swing occurring and there's no spin involved, then that will be a pure swing. If there is spin involved, then it's an impure swing. So in the knee, for example, you will have an impure swing at the ends of ranges of flexion and extension, and a pure swing in the mid range. And the reason for that is, as I get to the end of extension of the knee, about the last 20 degrees maybe or so, then all of the movement is taken up on the lateral condyle, the lateral tibial surface and femoral condyle, because that's a smaller joint space. So it stops there, but the medial epicondyle keeps on moving forwards of the tibia, and that results in a lateral rotation of the tibia. So mid-range, there is no impure swing, but the impure swing occurs at the end of range. So in order to get full range of motion at the knee in extension, you need a lateral rotation of the tibia. To get full range medial rotation of the knee that is full flexion, then you need medial rotation of the knee. Now, if you're looking at the shoulder, because it's got 3 degrees of freedom, it does have a spin, whereas the knee has no arthrokinematic spin. Everything's translating. So, but the shoulder it does. So we can have a spin which in this case is flexion and extension, providing it's done properly. This isn't elevation now. This is flexion and extension across the body, remembering that the the glenoid is facing anterolaterally, so that the movement has to be in that plane, and that will give you a pure spin across there, like so. So it's coming across your body. This is an impure swing, because it involves also lateral rotation, because I'm in abduction now and I'm doing flexion, and to get full range it has to laterally rotate as well. But even in mid-range, as soon as I come out to that point, I'm going to do flexion and abduction, because I'm abducted to where it should be. So you've got two movements combined. One of those is a spin, you have an impure swing. It's as simple as that, basically. I'm sure we talked about more than that, but I think that pretty much sums it up. If you have any questions about it, just email me, okay? And I'll be happy enough to do something about it. But I think that's all we talked about there, and then the rest of it got taken up. All right, guys, I'll do a summary of this as well, because some interesting points came up on the Zoom, and I'll tack that onto the end. All right, guys, enjoy the rest of it.
It's okay.
Okay, let me do that again. All right. Now I'll make an extra video on it. You good with that?
Mm-hmm.
All right. So the pure swings are what is actually proper abduction, there to there. All right. So it's in the plane of the scapula. Remember, this is off kilter. So it's the glenohumeral joint is facing anterolaterally. So this same movement has to be in that plane. So this is ab and abduction. If you do it out from the body, this is ab and adduction and lateral rotation again. So you're combining two swings, which means it has to be an impure swing.
Okay.
Okay, so that's one of them. The other movement, ab and adduction, flexion, extension, medial and lateral rotation. So again, it's translating. The only movement it doesn't translate with is flexion and extension.
Okay. To a certain point.
Well, full range.
Full range.
Because as soon as you go further than that, you stop doing flexion and you become a combined movement. Whereas extension of the knee, where the conjunct rotation kicks in, that's still extension. But you come out of flexion, that's its full range. You cut as soon as you move out of it, then it becomes a combined movement.
Okay.
And it's the same with abduction. If I get up too high, I can only go so far with this because I need lateral rotation to get any higher. So that becomes an impure swing at that point.
Okay.
Right. Now that's for joints with 2 degrees of freedom for the knee, 3 degrees of freedom for the shoulder and hip. But for joints with 1 degree of freedom, that conjunct rotation is there through almost the entire range. There's not much. The two ends might be a pure swing, but for the most part, that conjunct rotation occurs almost all the way through the full range. So you never get a pure swing, or if you do, it's minute with a joint with 1 degree of freedom.
Okay.
Okay, everybody?
Thank you. That makes a lot.
All right. Rachel, you got anything? No? Okay. John?
So relating that to, let's say like with a patient case of like adhesive capsulitis. So it's very often that you seem to get that flexion and you're like, oh, great. But then obviously this is what lacks, right?
Well, yeah, that's an interesting point. Hang on a minute. I just thought of something.
Mm-hmm.
Okay. Yeah, that's an interesting point. according to Syriac, a capsular pattern for the shoulder, which is incomplete. It's definitely incomplete. But the capsular pattern that Syriac describes is restricted abduction, then, restricted lateral rotation, then abduction. He never talks about flexion and extension. So, and that's obviously that's just incomplete. The flexion extension must be affected. But presumably it's less affected than is medial lateral rotation and abduction. So you may get a small amount of pure flexion extension, but it ain't going to go too far because you won't get full range because it's limited by the capsular problem. So as soon as that happens, they try and go outwards, then they're going to be limited by the lateral rotation. If you want to check how much flexion and extension they've got, you have to do the joint glide. So what do you think the glide is for flexion and extension?
I'd say it's the flexion part being a pure spin. I'm not really sure. I guess that's what I'm kind of trying to piece together is the arthrokinematics of which way I should.
You should be a bit puzzled. So anybody got an answer to the puzzle? You should be puzzled. You can't do a translation. That's what you can't do because it doesn't translate. So what can you do?
So I'm going back to school days, thinking about arthrokinematics, flexion, extension, posterior glide. That's
a translation. That posterior glide may be for elevation.
Okay, not flexion.
That's debatable, actually. That is debatable.
Okay.
Because elevation is lateral rotation, abduction, and flexion. So if you're going to, like the combined glide for that, should be anterior because of lateral rotation. And as you're coming back into this position, that should also be anterior.
Yeah, so the reason I ask is, like with these patients, I've been essentially like kind of carpet bombing them with, posterior, anterior, and inferior glides.
Okay. Why can't it do that? If you've got a restriction of flexion and extension, why is it can't do that? Actually, same thing. Yeah. Why can't it glide forward? Why can't it glide back? What's stopping it from gliding?
The capsules.
The capsule. Right? Okay. Yeah. So you're testing the capsule. Presumably it's not a label term. Let's say it's a capsular problem. So you're testing the end fill of the capsule when you do an anterior glide for lateral rotation, say. Okay. So is there a way of testing the capsule for flexion and extension? What you want to do is
maybe traction.
Stability.
Could you do traction potentially? See if it just.
As long as you're producing distraction.
Distraction, which is
okay. Yeah. So it's not. It depends on how you define traction, but I think we talked about this at some point, didn't we? If we redefine traction not as a pulling force because it's not much use, if we redefine traction as a force that tends to produce distraction, then yes, traction. But you're going to do that with it and see if you can pull it out. That's the same thing you do with the radiohumeral joint, because structurally that's a ball and socket joint. Even though it's only got 2 degrees of freedom, it has a pure spin. So you'd have to test distraction for that as well.
Is there a certain plane you test the distraction in? So would you put them
neutral? Well, yeah, you could do. There's a couple of different ways of doing it. In a big joint like this, you could take it to the end of flexion, but you can't afford to go past that point. Because as soon as you come out of flexion, you do that, then you're basically testing something out of the movement. But if you come to the end of where you think flexion should end, and you can actually be careful, if you do it carefully, you can, I don't know if you can see this, but if I come from here, you can see it's going outwards. I'm not doing that, but it's doing it. If you're careful with that and you stop when you see it's starting to move out there, and then try the distraction now, if you've got distraction available, then flexion is full range. Okay. If the end feels normal. Otherwise, with more severe problems, you can basically test it in neutral. So if this is an arthritis or a severe arthrosis, like when you're getting all that grinding sound going on in the shoulder, if you test it in a more neutral position, you'll be able to distract it enough to get that hard end feel that you shouldn't be getting. So yeah, you could test it both ways. But with a non-severe problem, you may have trouble picking up that end feel in the neutral because you've really got a yard on this thing. But with more severe one, you should be able to pick it up in neutral.
I have a quick question. That's
Go ahead.
kind of confusing. If you're limited in flexion, you're saying do an anterior
No,
mobilization?
I'm saying you explain it to me because I don't understand it. Like if I do that, okay, if I come into elevation, the argument is that this is gliding backwards. All right. But to do that, I have to have lateral rotation. I can't try and do that immediately. Try it. Immediately rotate your arm and elevate. You can't do it. It doesn't work. So, because what happens now is your scapula does it. Yeah. So if you need lateral rotation. If lateral rotation is limited, you can't elevate. If lateral rotation is limited, that's an anterior glide.
So most people that I guess I'm seeing with shoulder problems, their shoulders already sitting so far
I don't care.
forward.
That doesn't matter to me
Why
anymore.
would you glide it further? Like
Well, no, you're looking at the shoulder girdle being anterior, not the shoulder, not the glenohumeral joint. If the glenohumeral joint is sitting anterior to where it should be, it's unstable.
Yeah.
Okay. It's just the shoulder girdles are rounded off. Like they've got that posture. That's everybody pretty much, except for us athletes. We're a bit better at it. But that's
if your shoulder girdle, if your shoulder girdle is anterior, that's a good sign. Correct me if I'm wrong, Ed, that the anterior capsule would be tight, right?
No.
Because being back, and you would tighten it by. Wouldn't you think that would
you cannot tighten your capsule.
Right. But if it is tight, wouldn't it pull the scapula more anteriorly?
If what's tight?
Say the anterior capsule of the
No, I mean you're assuming that the forward shoulder girdle is due to the shoulder capsule. Why? This is just postural. It really doesn't have. Why did the capsule get tight?
I wonder. I guess that's what I'm hypothesizing. Is like if over time you've just been in that posture for so long,
then it's the posture that's caused it, not the anterior capsule.
Right, but that could potentially shorten the capsule.
I don't know that it would. I don't know that it would. Can they do that? Because if they can do that, they don't have any structural shortness. If this is just habitual, have you ever seen competitive swimmers? When they walk up to the blocks, they look a goddamn mess. Yeah, shoulders are their heads forward, and then they swim at racing speeds. They don't have a structural forward posture. Otherwise, they couldn't swim like that; they'd drown. So the assumption that a position shortens stuff is really not that well founded. There's not a lot of evidence for it, if any.
I think if anything, it would be more of an impingement problem. But I don't know if it would be like a joint, because I feel like a capsular issue would be from like a trauma or from surgery, or something like that. I don't like, because if you think about the forward posture or you think about like internally rotating your shoulder with elevation, you can't do it because you have that. It would be like a functional impingement kind of a situation.
Yeah, that's exactly right. There's no evidence for adaptive shortening. You know, the stuff you see coming out of a cast, they get their range of motion back really quite quickly, except for what the trauma's caused, the scarring that the trauma's caused. But they may well be limited in all ranges, but that comes back in one direction very quickly. couple of days usually. And what they're left with is whatever the trauma's caused. They used to do immobilization of two joints. They still do sometimes in a cast for 6 or 8 weeks. The aeroplane casts were a case in point. They still do those? Has anybody ever seen one? It was for a fractured humerus. So you'd have the arm in this position and cast it from the elbow, including the shoulder, and have a pole coming out of there, holding it all together. Well, as soon as they took the pole away, the shoulder fell down. So that wasn't adaptive shortening. And they could move the shoulder around after a few days. What they couldn't move terribly well was the elbow because of the fracture, or the shoulder. The elbow moved fine, or the shoulder if the fracture was up by the shoulder. But the other joint that was really unaffected by the trauma came back almost immediately. So there's no real good evidence for the idea of adaptive shortening. So it's a cart and horse situation. What caused what? In fact, if you think about it, if the anterior posture was maintained over a prolonged period and stressed, you would expect to see an anterior instability of the glenohumeral joints. Yeah, nothing to do with the posterior capsule. So why would the posterior gliding be a problem? And if you've got a tight posterior capsule, if you do get one for any reason, it's going to hold the shoulder back. And that should limit natural rotation.
When we were talking about too, just like the elevation versus pure flexion, because I could understand how that would get confusing. Like I'm a very visual person when it comes to arthrokinematics. So for me, if I know that like pure flexion, they're not very limited, that's fine. But if they come out here and I know they've
this is not pure flexion. This is over here.
Oh yeah.
Okay, that's your angle there.
Yeah.
This is elevation.
With the joint. Yeah. So like for elevation, if I know somewhere out here is where they're limited, I pretty much from a joint mobilization perspective, I go through the body pretty much with my mobilization. So I know if they're limited, like with elevation and external or like flexion, elevation, abduction, I'm pretty much going to mob them like medially, posteriorly, inferiorly, because that's pretty much the opposite that joint is moving. I don't know, because like in school we said like, well, flexion is like a superior anterior roll, so that would be a posterior inferior glide. So we kind of learned it that way, but I know that a lot of people come out, I would just do like the opposite of the motion if it was this joint, like a shoulder, like a ball and socket kind of joint.
Well, let's get the theory out of it, shall we? The definitive test for a joint is the joint glide. So whatever joint glides are restricted, that's what you treat. That's really easy. Yeah. And basically, it's a good idea to test each one individually. So you do inferior, posterior, anterior, and so on. You do each glide individually. And then basically what you find is positive is what you treat. It takes all of that theorizing out of it. And elevation's a complex movement, very complex movement. And the gliding directions will differ depending on what part of the range you're in and how dysfunctional it is. So I think that theorizing this is pointless, and it's almost certainly going to be wrong anyway. Check the glides, deal with the glides, and you've got it. What you need to concentrate on is rehabilitating the movement patterns that you need to rehabilitate, which has nothing to do with the glides. And your big problem with the shoulder and with other joints, but particularly with the shoulder, is antalgic patterns of movement. So you see this reverse scapulohumeral rhythm when they do that and they can't get their arm up. Half of that is because they can't get the scapula out of the way.
Brad, can you mute yours things, please?
Oh, you come on last, Brad, and you disturb everything, for God's sake. So
That's me making my intro.
Yeah, well done. One of the things you can do for that actually is if you have their arms by their side and you just pull down on their fingertips, so you're pulling it very gently downwards, and you tell them to push down and out as they're elevating their arm and you're pulling to it. You're not pulling everything down. You're just guiding the movement so that as they're bringing it up, they're pushing that out all the time. And that helps keep the scapula down. So they should increase their range pretty quickly by doing that. But this is all about antalgia and learning habits. Even when the pain goes away, they're still doing that. Same as when you have pain in the leg and you limp. That limp will persist long after the pain's gone away, possibly forever, if you don't do something about it. And this is exactly the same thing. It's an antalgic movement. And that's usually the biggest problem with the shoulder. Because something like a capsulopathy, frozen shoulder disease, or whatever you want to call it, the movement will come back with or without you. Yeah, it'll get better in 6 months or it'll get better in 18 months. These seem to be the way it works. 3 months freezing, 3 months frozen, 3 months thawing. Yeah. So, or 6 months, 6 months, 6 months. But eventually it recovers with or without you. Not completely because nobody's rehabilitated the movement, but they get their movement back and the pain's gone. What you do is shorten that down. You can shorten that time down and improve the pain rapidly, and then you can rehab it as well. So, I don't know where I was going with that thought, actually.
So if you did have a purely flexion restriction, would you then take them to the end range of what they can do and then perform distraction as a treatment? That's the move or glide.
Yeah.
Okay. And then secondary, have you ever seen like so I think about last, I may be totally wrong about this, but you speaking of swimmers, it kind of made me think of it. Have you seen pseudo adhesive capsulitis caused by like lats or a subscap? Because I feel like those muscles would also restrict that motion, right?
It's
like
not that. It's not that motion though. Look, don't keep testing combined movements if that's what you're doing. You test lateral rotation, that is really restricted. You test abduction, stabilize the scapula, and that's really restricted. You test medial rotation, much less restricted. You test adduction, much less restricted. Yeah. So if you test out the individual movements and each one that's restricted, you then test the glide, you'll get an overall accurate picture of what's happening in the shoulder joint. Rather than testing combined movements, like doing that, because this is scapulothoracic, it's all sorts of things that's going to limit this. So individual testing of movements, individual gliding, and then what you need the big movements for are rehabilitation of function.
Okay.
Yeah.
And then, so say you're testing anterior, inferior, and posterior, would you retest? So say like they're obviously like super limited in external rotation. You take them to their end range and then do an anterior glide, for instance.
No, not usually. With a capsulopathy like that, you can usually pick it up in more neutral position. Okay. If not, then yeah, you take it out. And what you're trying to do is get to the end of range. You need to get to the end of the range one way or another, either through the arthrokinematic or through the movement, but you end up testing the arthrokinematic. So it's not about what the passive physiological movement feels like. It's about what the joint glide feels like, the arthrokinematic movement feels like. So you've got to get there one way or another. Like if it's severely painful, if you have, say, rheumatoid effect in it and it's in a flare up, you won't get anywhere near the end of range of either the glide or the movements. You'll get a spasm intervening where it's that acute. And the early stages of capsulitis, you're going to have exactly the same problem as well. So under those circumstances, you can say with a degree of probability, a fairly high degree of probability, that the joint's in trouble. But you can't be more definitive about it because you can't get test the arthrokinematic. And your job then is to get the pain down, the inflammation down, and make them comfortable, not to increase their range of motion by stretching things. You'll increase the range of motion if you get the pain down and the inflammation down. Yeah. So the glides under those circumstances don't matter because you're not dealing with the glides anyway. Like a bursitis, an acute subdeltoid bursitis can look very much like a capsulopathy, an acute capsulitis, and you won't be able to test the glides. Yeah. So arthrokinematic testing is definitive. Passive physiological movement isn't. Test the movements out individually. Test the glides out individually. And for rehabilitation, combine everything to rehab the movement. Best advice I can give you on that. I can remember I had Syriacs teach me what to do with a capsulopathy, and it's effective. But what you do is you lay the patient on their back, you hold their hand over the sternum like that, or that way, yeah, that way hold the sternum down, and this one comes onto their elbow. So you take them as high as you can, and you apply fairly light pressure to it. You put, and it's really painful. And you hold it as long as the patient will let you, and you let it off, and then you do it again. You let it off and do it again. And very often, after 3 or 4 treatments, it will suddenly go rip, and it sounds just like a handkerchief tearing, just rip, and the range will go back. And I remember the first time I did that, it did exactly that. And I'm standing there holding their arm down, holding their chest down. Their eyes are wide open, looking at me. I'm looking at them, going, "Oh God, what have I done?" And I went, "Still got their arm there." I said, "You all right?" He went, "Yeah." I said, "Did it hurt?" I went, "No." So I've still got their arm there. I didn't even let go of it. Well, Christ. And they were fine. You didn't get the flare up after a manipulation under anesthetic. They kept their movement. But that takes a lot of, you've got to have a lot of cooperation with the patient. But this is back in the good old days when the patient expected to be tortured when they come into a hospital. That doesn't happen anymore. So you've lost a really valuable treatment thing there because patients are wussies. So are the therapists, by the way. You've got to get in there and hurt them. Okay. So that was about joint surfaces. Anybody got anything else on anything else? No? Okay, let me show you this video then. See if I can find it. Oh, there it is. Can you all see that? Blackness. Okay. This is Tim. All right. This was sent to me by a therapist. I taught a motor vehicle course in Louisville years and years and years ago. And this is the patient he got in about a month after the course, and he videoed it. Actually, where are we? Okay. There you go. He sort of, he'll start again, I think. Maybe not. No, okay, I'll cut it. Okay, so we're going to try to do there you go. A little bit, yeah. A little bit. Okay. Let's do this. 15, 14, 13. Nothing too much wrong with that. 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. We'll do it in the other direction now. Okay. Yep. Get lightheaded or dizzy? Nope. Okay. In this particular test, we're going to hold the head still, and Tim's going to swing his body to the left. This would be a right. That's right rotation. This is the opposite rotation that he just did. So in this position, we'll be going into right rotation without any movement of the head, which should rule out the vestibular system. And Tim, what you're going to do is the same thing. Once you turn and your body's going this way, I'm going to hold you still. Yeah. You're going to count backwards from 15 out loud. Okay, you just let me know if you get lightheaded or dizzy. Yeah. Okay, go ahead and begin. Turn your body. There you go. Now start counting.
Okay, 15.
Now look at his pupils.
Okay, that's good. Okay, what you're gonna do now, you're gonna turn, I'm gonna hold your head still, but you're gonna turn facing forwards, okay?
Can
You're
you
gonna
guys
start
still long enough?
counting backwards from 15 out loud. You let me
That
know
one,
if
I
you get
think.
lightheaded or dizzy.
No, actually,
All right?
I can't remember now. I
Go
think it's
for it.
that one. But watch what happens over time with this.
15, 14, 13, 12, 11, 10, 9, 8, 7.
That's left rotation,
5,
which was fine.
4, 3, 2, 1. Now turn back to the left. Any problems, lightheaded or dizzy? No. Okay. It didn't show what Tim's body was doing, so I'm gonna go ahead and show
It's got to do it again.
what he was doing on that particular part. We're trying to mobilize the head. Okay, swing your legs and body to the
Left
other
rotation again of the
rotate.
head,
We're trying to mobilize that
which
so
was
we can get
fine.
rotation without movement, okay, of the head for the vestibular. Try to rule out the vestibular system, okay? Stop. All right, we're gonna do this one again. It seemed like the last time we didn't have him really good in focus.
So we do it again. This is right rotation. Watch.
See what I noted the first time was a deviation of the left eye to the midline and a little bit of quiver or nystagmus. So it's the same thing, Tim. You count backwards from 15 out loud, Tim, if you get lightheaded or dizzy. All right, look the camera.
Watch that eye. It's the left one. See it?
15,
Going in.
14.
And he stopped counting.
You okay? Yeah. Okay. Okay.
Look at me.
All right. Let's get in there.
Let's check to see he's still alive.
Technicians hold the camera because I tried to do it, hold the camera. I couldn't get it. That was too close to him. So I hope you were able to see that. When I do the test, ideally, I'm very close to the patient. I'm maintaining eye contact. I ask them to look at the end of my big nose. Sometimes what we can note is one pupil may dilate, one pupil may constrict. With Tim, the left pupil tends to dilate. And I hope in that last test you could see that his left eye converges or adducts towards the midline, and we even saw a little bit of the nystagmus. So I hope those things can come out on the film and you can see that. And we hope this can be a help. Thanks a lot, Dr.
You ain't
Johnson,
done
for the
yet.
referral. Okay, some other vestibular tests just to see if
That
motion
pupil,
is
I don't know if you
causing
can
some
still
of this.
see it there or
We
not.
actually hold the patient's neck still and move their body and then stop and see if we get any nystagmus.
I think they get a bit closer in.
We'll do that now.
But this, yeah. This one's not bad. Watch when he goes backwards and forwards. This guy grits his teeth. So you can see Birdie go with him.
Stop.
He's lost it a
And we
bit
see if
there.
the patient's dizzy or lightheaded. You okay with that? Yeah. Okay.
Little minister. Watch his teeth. There he goes. So he's biting his bottom lip there. Look at him.
You okay with that? Okay.
I would have stopped testing this some time ago, and it's the second time around for this kid, this guy.
I don't know if we'll be able to pick this up.
But that left pupil blew right up.
I think it's the
You can't see it very well.
We had a little trouble with that. So he's going to track my finger, and we'll see how.
And this is amazing as well.
Follow my finger. And he's able to converge and hold. All right, now follow my finger.
Right there. And he almost loses consciousness in one of these movements. That one.
Can you see that? Was my hand in the way?
No.
Okay, the upper right, he has a lot of stuff. Follow me again, fellas. Are you dizzy now? Tell me when you're better. All right. Just warm me up a little bit here.
Oh, yeah.
Follow my finger.
I think this is the worst one. There you go.
And it's to the right. Anytime he brings in the right, you okay? Seems like any actual or ocular motion to the right, and seems to exacerbate some of this dizziness. Okay, Tim, I want you to stick your tongue straight out, all the way out.
He does deviate to the right, see it?
Okay, come back in. Okay. Slight deviation to the right there. Smile real big for me. Okay, a little asymmetrical. And frown real bad for me. Okay. Okay, some of these things are cardinal signs. So when we have these type of reactions to our testing, we want to some and like again, thanks for referrals and please again.
You couldn't see the pupil. The pupil blew right up there.
We're going to try to do the
It
vertebral artery.
was quite amazing. What he did was he sent that video to the patient's doctor, and the doctor sent it to a neurologist, and the neurologist said the patient was faking. You know, the guy's obviously not highly educated. I'm not saying he's stupid, but he's not got a lot of education. And he wouldn't know what to fake. And if you could fake it, you can't fake a blown pupil, and you can't fake that sort of convergence of one eye and not the other eye. You know, it's a ridiculous thing to say, but that's what he said. Guy's still alive, as far as I know. This is a long while ago, but he lived past that. So it was a motor vehicle accident. But what amused me was that it'd been tested at least once before, in order to then to get the video out, and then retested him when the particular shot he was trying to take didn't work out too well. So he was taking a bit of a risk there, but that's probably the most persuasive video I've seen on vertebral artery stuff. You see isolated positive cranial nerve signs on videos, and you should look it up. Go and look up these signs if you haven't already done it. Look up positive signs for the cranial nerves because they're interesting. But that on a patient is probably the most comprehensive one I've seen. The other video I'll send you, if I'm sure I sent it to Scott, but if not, I'll send it again, is an X-ray on fluoroscopy. It's a bit longer, and that one is scary. It's absolutely scary, but I'll send that to you. All right. Okay, I've got to work on some sample question papers for you, and I'll do that, and I'll get those to you, and then we can start discussing some of the questions you're likely to get on the written test. All right. I have to redo the beginning of this video. Rachel. All right, nothing else for me?
Daria did remind you to do it.
She said, "Oh, have you done it?"
And you didn't start it yet.
I said, "Not yet." Not my fault. Ain't my fault. It's never my fault. You've got to get used to that. All right, guys. I'll see you next week then.
Thanks, Jim. Have a good day.
Bye. You too.
Bye.
Bye. So I said I'd sum up. First of all, maybe now you can understand why the biomechanics, the more theoretical biomechanics, is so important to your clinical practice. There's only a few things you have to keep a hold of here. Is if a convex surface is moving on a concave surface, the arthrokinematic is in the opposite direction to the osteokinematic. So if, for example, the knee is extending, then the tibia, which is concave, will also move anteriorly. But if you getting up from standing and extending the knee that way, the posterior glide of the femur would be posterior while the leg is moving forwards. So that's the main thing to take from it. It's not the only thing by any means, but it's the main thing. The arthrokinematic, if it's a concave surface moving on a convex, the arthrokinematic is in the same direction. If it's a convex on a concave, it moves in the opposite direction. So if we look at the shoulder, for example, I was told that elevation is a posterior glide. You were told it's a posterior glide. And that may well be true to about 90 or even 100 degrees. But you start coming back there and the whole arm is starting to move backwards now. So the only way the convex humeral head can move now is forwards. So when you're testing combined movements and functional movements for biomechanics, this is where it gets to be complex, you're basically looking at changing axes through these ranges. Whereas if you're concentrating on the end of range, which is all you're interested in with range of motion, if you're up there, then you know that this thing has to be gliding forwards if it's going to go further in that direction. So you know the glide for that must be forward. But you can even get round to that. So there's no debate at all. And check individual movements. So lateral rotation, if you check the glide for that, you can feel what's happening. The humeral head tends to come forward. It bulges against your finger. If you're doing medial rotation, it glides backwards. If you're doing abduction, it wants to glide inferiorly. Always remembering that if you've got good dynamic stabilization, the muscle control, it won't glide at all. So, and of course, for a pure spin, it's a distraction movement. Now, there are joints that have a pure spin. That is, it's an unmodified ovoid surface. But that joint only has 2 degrees of freedom. The radiohumeral joint is probably the prime example of that. The surfaces are an unmodified ovoid. It has a spin that allows basically pronation and supination to occur. But because the ulna and the radius are tied together, the number of degrees of freedom that is allowed on the radius is limited by the number of degrees of freedom on the ulna. So it's only actually got 2 degrees of freedom, flexion, extension, and pronation and supination. But you need that spin to allow pronation and supination to occur freely. And that's why it's shaped the way it is. So don't check combinations when you look at ends of ranges and you're looking for the biomechanics. Don't check combinations of movements. Check the individual movements. Okay, and that makes the whole thing easier. There's less debate about it. But also remember that the arthrokinematic is definitive. If the arthrokinematic is limited, it's an articular problem. If it's not limited, then the joint isn't involved in that hypomobility. And that's about all you have to remember. So any questions, email me again. All right, take care all. Bye.